guys, Handsome Nerd ASMR, back with another video. In this video, I want to break down in detail the difference between osteoarthritis and rheumatoid arthritis. So let's get started. Here's a nice table that can help you to differentiate between osteoarthritis and rheumatoid arthritis in several ways. So, osteoarthritis is classified as a degenerative joint disease, while for rheumatoid arthritis, it is classified as a systemic autoimmune inflammatory disease. So, with that being said, the primary problem behind osteoarthritis is there is mechanical cartilage breakdown, while for rheumatoid arthritis, there is immune-mediated synovial inflammation. And this can be shown by this figure right here, where the synovial parts of the joints are inflamed. Regarding inflammation, there is minimal inflammation in osteoarthritis, and if there is, then it is more secondary in nature. In other words, it's secondary to the cartilage breakdown. So that's why there can be little to no inhibition or little to no inflammation in osteoarthritis. But in rheumatoid arthritis, there is pronounced inflammation to where it is central to the pathophysiology behind rheumatoid arthritis, and such inflammation can be destructive. Finally, in osteoarthritis, there is not necessarily a systemic involvement, but in rheumatoid arthritis, there can be systemic involvement where multiple organs can also be affected, which makes sense because it is part of some autoimmune inflammatory process. Now that we understand some differences between osteoarthritis and rheumatoid arthritis, let's break down these diseases based on their pathogenesis. For osteoarthritis, it is due to an imbalance between cartilage breakdown and repair. So, over time, as we continue to use our bones and our joints through exercise, the mechanical stress can lead to chondrocyte dysfunction, and this results in loss of articular cartilage. Also leads to subchondral bone sclerosis and osteophyte formation. Osteophyte is basically a medical term for bone spur. So, the key behind osteoarthritis is chondrocyte dysfunction and the ultimate imbalance between cartilage breakdown and repair. As a result, inflammation is secondary in nature, and it does not drive the disease, unlike in rheumatoid arthritis. And the key mechanisms involved will be increased presence of matrix metalloproteinases and decreased proteoglycan synthesis. And also, there's obviously going to be chondrocyte apoptosis, and these mechanisms will contribute to chondrocyte dysfunction and imbalance between cartilage breakdown and repair. Now let's talk about rheumatoid arthritis. So, rheumatoid arthritis is an autoimmune disease with loss of self-tolerance, and this occurs due to the CD4 plus T cells, which activate the macrophages and the B cells. There is going to be autoantibody production, which specifically involve the rheumatoid factor and the anti-CCP antibodies. There's also going to be cytokine-driven inflammation involving the TNF alpha cytokine, interleukin 1, and interleukin 6 cytokines. TNF alpha stands for tumor necrosis factor alpha, and a key pathological process involves synovial hyperplasia, which leads to the formation of pannus, and then the pannus will erode the cartilage in the bone, which then leads to deformity. So that's the difference between the pathophysiology of rheumatoid arthritis versus osteoarthritis. Let's remember that there is autoantibody production in rheumatoid arthritis, such as the rheumatoid factor and the anti-CCP antibodies, and that you're going to have T cell or the CD4 plus T cell activation of macrophages and B cells. Let's move on to the epidemiology and risk factors for these two diseases. So for osteoarthritis, it happens to be very common, and the prevalence will increase with age. And so the risk factors to watch out for include aging, obesity, prior joint injury, repetitive use such as in prolonged exercise, genetics. Another interesting thing about osteoarthritis is there is slight female predominance, especially in the knee, where more females than male are susceptible to this condition. On the other hand, rheumatoid arthritis is less common, and the peak onset of this condition is between 30 to 50 years of age. Once again, there is female predominance, where the prevalence of rheumatoid arthritis among females compared to males is 3 to 1. And so the risk factors to watch out for include genetic risk factors such as the defect in the HLA-DR4 gene, and then the smoking is known to be strongly associated with the rheumatoid arthritis. And as we mentioned earlier, the female sex, as female predominance, is known to be, or I should say, as rheumatoid arthritis affects females more predominantly than males. Alright, now let's talk about the joint distribution and clinical presentation of osteoarthritis and rheumatoid arthritis. So for osteoarthritis, the joints that could be involved include weight-bearing and high-use joints. So the knees, the hips, the spine, and also the hands can be involved. For the hands, the distal interphalangeal joints and the proximal interphalangeal joints will be most likely affected. But on the other hand, the metacarpal phalangeal joints will usually be spared. And that is indicated right over here. As you can see, the metacarpal phalangeal joints are spared, but the proximal interphalangeal and the distal interphalangeal joints can be affected. For symptoms, the pain will be worse with the use of the joints, but relief by rest, and the morning stiffness will occur for no more than 30 minutes on average. There's going to be signs of crepitus and a reduced range of motion. Upon physical exam, you might find Heberden nodes located on the distal interphalangeal joints and the Bocard nodes located on the proximal interphalangeal joints. There may also be bony enlargement with minimal warmth. Alright, for rheumatoid arthritis, the joint involvement is going to be more symmetric in nature, unlike in osteoarthritis. And then the characteristic of this involvement is that it is a symmetric inflammatory polyarthritis. So, although multiple joints can be affected, the ones that typically are affected include the metacarpal phalangeal joints, the proximal interphalangeal joints, and the wrist. On the other hand, the distal interphalangeal joints are usually spared. And that is really how you distinguish between rheumatoid arthritis and osteoarthritis. For symptoms, the pain can get worse after resting, and the morning stiffness can usually last for greater than 1 hour. Patients can also present with fatigue and low-grade fever. And then for physical exam findings, you might find warm, swollen, and tender joints. And then for deformities, they can involve ulnar deviation, swan neck deformities, and boutonniere's deformities. This will occur in later stages of the disease. And the ulnar deviation can be shown over here as the fingers or the digits are deviating more towards the ulnar side rather than the radial side. So, those are some ways to distinguish rheumatoid arthritis from osteoarthritis. And then for extra-articular manifestations, these will apply to rheumatoid arthritis only, as rheumatoid arthritis is systemic in nature, while osteoarthritis is not. So for rheumatoid arthritis, some extra-articular manifestations to watch out for include rheumatoid nodules on the skin, interstitial lung disease, or even pleuritis regarding the lungs, pericarditis, or inflamed pericardium regarding the heart, scleritis in the eyes, vasculitis in the blood vessels, and then anemia of chronic disease regarding the hematological system. For laboratory findings, these are some tests you should order. First one being the erythrocyte sedimentation rate and the C-reactive protein. Because for osteoarthritis, these levels may be normal or mildly increased, while for rheumatoid arthritis, they're going to be quite elevated. The rheumatoid factor is going to be negative in osteoarthritis, but it's often going to be positive in rheumatoid arthritis. And then the anti-CCP antibody is going to be negative in osteoarthritis, but not only is it going to be positive in rheumatoid arthritis, this antibody and test is highly specific for rheumatoid arthritis. So, if this has a positive result, then you can guarantee with a significant degree of certainty that the patient has rheumatoid arthritis. And then for complete blood count, it may be normal in osteoarthritis, but in rheumatoid arthritis, patient might be a little bit anemic. And then for imaging findings, of course you're going to order an x-ray, because in osteoarthritis, the x-ray is going to show joint space narrowing. Although such narrowing is going to be asymmetric in nature, it's also going to show osteophytes, subchondral sclerosis, and subchondral cysts. And then for a very helpful strategy to remember these key findings on x-ray, think about the mnemonic law. loss of joint space. O stands for osteophytes. S stands for subchondral sclerosis, and another S stands for subchondral cyst. For rheumatoid arthritis, the X-ray findings will indicate or show symmetric joint space narrowing, unlike in osteoarthritis. Because remember, osteoarthritis is asymmetric, while rheumatoid arthritis is symmetric regarding joint space narrowing. The X-ray will also show marginal erosions in patients with rheumatoid arthritis. It will also show osteopenia near joints, and then in early stages there may not be osteophytes. And then, if MRI or ultrasound is ordered, it can show some presence of synovitis and bone marrow edema. Regarding histopathology and biopsy, the osteoarthritis will show fibrillation and erosion of cartilage, the thickened subchondral bone, and an minimal synovial inflammation. But in rheumatoid arthritis, there's going to be hyperplastic synovium, an intense inflammatory infiltrate, because once again, it is an autoimmune inflammatory disorder or disease. There's also going to be the presence of pannus, which destroys the cartilage in the bone. So with that in mind, we have some treatment and management principles for these diseases. So for osteoarthritis, the objective is to work towards symptom control and function preservation. So ensure or work towards weight loss and exercise. Prescribe NSAIDs or acetaminophen. NSAIDs are non-steroidal anti-inflammatory drugs. Physical therapy is also important for patients with osteoarthritis, and then joint replacement should be considered in late disease stages. Unfortunately, no disease-modifying therapy seems to exist to date. For rheumatoid arthritis, early aggressive treatment is important, and thankfully we have disease-modifying anti-rheumatic drugs, or DMARDs. These include methotrexate, which is a first-line anti-rheumatic drug, and then we have some biologic agents like TNF alpha inhibitors or interleukin 6 inhibitors. These will probably end up being monoclonal antibodies that target these things. Of course, prescribe your NSAIDs and steroids for symptom control, like glucocorticoids. Symptom control typically involves pain control. And then the ultimate goal is remission or low disease activity. So to sum things up, osteoarthritis involves mechanical cartilage degeneration with pain that becomes worse on use. There's minimal inflammation and bony changes will be involved. For rheumatoid arthritis, it involves autoimmune inflammatory synovitis, which causes symmetric joint destruction and systemic disease. So that's really how you distinguish